Good afternoon. This is Diane Rolfsmeyer with the Nebraska Medicaid EHR Incentive Program. Welcome to our webinar this afternoon, the title of which is Attesting, Common Questions Explained. Welcome to everyone who took the time over your lunch hour to be a part of this educational webinar. We appreciate it. I would remind all attendees to please mute your phones so there's no background noise that interferes with the presentation. Next slide, please. This slide outlines the vision, mission, priorities, and values as set forth by our Governor, Pete Ricketts. These items are designed to promote efficiency and to better serve the citizens of the state. Next slide, please. This is our overview for this afternoon's webinar. My name is Diane Rolfsmeyer. I'm a program specialist with the EHR Incentive Program. With us today is Karen Moran, also a program specialist, and we are being handily assisted by our assistant, Lavana Mosslander. We are privileged today to have panelists who have lengthy experience in assisting providers in the attestation process, and I think you will find their input valuable, and we appreciate the panelists for taking their time as well to be part of this program. We have Stacy, Ruthann, and Angela as our panelists. The discussion items today were gathered together on the part of the staff. It has been our experience over the years that we have found these particular issues to be persistent roadblocks to the providers in their attestation process. So we are going to be discussing how can I best organize for attesting, what documents need to be attached to my attestation. We will explain how the calculation of patient volume is done. How do I obtain my certified electronic health record technology number? How do I get the meaningful use data I use to attest with? And lastly, what is Nebraska's review process and how long does the review process take? At the end, we are going to ask you to stay with us for a little bit longer and respond to our email address with a webinar survey. We would like your input to determine what other topic items we should bring forth in a webinar format. We will also have a question and a wrap-up. Again, I would urge you to, if you have questions throughout the webinar, to put those questions in the chat box, and we will call out the question and identify the person who's put the question there, and if you have any follow-up questions, you are free to unmute your phone at that time, identify yourself, and ask your follow-up questions. I'm going to remind attendees again to put your phones on mute, except for the panelists, to eliminate any background noise. And I want to remind you that this webinar is being recorded and will be available on our website at a later date. And so with that, I believe we are ready to begin the webinar, and Karen will start the next slide.
Hi, this is Karen Moran, Program Specialist with the EHR Incentive Program, and I will be going over the slides. Going through the slides, and then Diane will be asking our panelists for input when the slide is done. So on this slide, how can I best organize for testing? We have a tip that we'd like to share. We have found working with providers and attestations over the years that it helps to keep data electronically if at all possible. If you're attesting for yourself as a provider, or if you are helping multiple providers attest, electronically keeping a file for each provider that contains all of the needed information and documentation seems to work best. This helps make attesting more organized and efficient. This type of preparation will assist with the current attestation year as well as attesting in future years. Include documents in your electronic file that you will be attaching to the attestation. the other slides of this presentation will go over what needs to be attached to your attestation.
This is Diane, and before I put forth the question to our panelists, I was very remiss in not sharing the bios briefly. This would be helpful for the attendees in showing the experience of our panelists. Stacy is an RN and nurse informaticist who has been at Children's Hospital and Medical Center for almost 19 years, the last 8 years of which have been in the IT department. She is currently the manager of the ambulatory clinical application and leads the Meaningful Use Attestation Program for children. Ruth Ann is a medical laboratory scientist, MLS, and the manager of the lab at the Grand Island Clinic. She has been with the Grand Island Clinic for 23 years, and her duties include helping with regulatory compliance and reporting. And lastly, Angela is a quality support coordinator with the Quality Support Department at Nebraska Medicine. For the past 2 years, her focus at Nebraska Medicine has been coordinating the meaningful use programs for the eligible hospitals and professionals, as well as the Physician Quality Reporting System, PQRS. As she continues to support meaningful use, she is also working on the transition to the MIPS program and helping her organization transition to the Medicare Shared Savings Program. So I think you can find that our panelists will provide a wealth of experience and information. So with that, I'd like to pose the first question to our panelists, and for the three panelists, please, when you are ready to answer, unmute your phone and identify yourself. Could you please give some examples about how you organize attestation data prior to attesting?
This is Stacy Duha from Children's Hospital and Medical Center. We have store all of our documents electronically on a common drive in our organization that is locked down to certain folks who work with meaningful use, so not everyone has access to all of the information that's contained in there. We do break it down similar to what some of the tips are on there by year of attestation, as well as any other supporting documents for that specific year. And then we further break down that year attestation data by provider. So each provider has their own folder, which we store all of their information in, so it's easily accessible. And if we need to go back and review, we can do that certainly by the year or by the provider without having to dig through hundreds and hundreds of files.
Very good. Any other panelists like to share?
This is Angie with Nebraska Medicine. We follow a very similar process to Stacy at Children's, where we keep it on a common drive where only the certain people who deal with meaningful use can get to it. And we also break it down by year and then break it down by each individual provider and keep their individual data in that section so that we can always go back and find it if we need to, as well as keeping any documentation that we get from our vendor or from the state or anything like that on that drive as well. Scan it in if we need to, but everything is right there in one location so we can always find it by year.
Thank you.
This is Ruth Ann Broad from the Grand Island Clinic, and I found this tip, keeping things in electronic files, to be helpful to me, because that's not really something that we've done so far. We're a smaller organization, and so far we've mainly kept our documents, paper documents, in paper files, and kind of at the end of the year, as we need them for attestation, we scan them in so that we can electronically send them. But up until now, we pretty much have been working with paper files.
Thank you.
Next slide, please. Okay, on this slide, we discuss, again, some more tips on how to best organize your information for attesting. Specifically, similar to keeping the other attestation data electronic, we encourage patient encounter data to be kept electronic too. We believe that this will assist in keeping all documents related to patient volume together. During attesting, the provider should attach verification of their Medicaid patient encounters to the patient volume questions page. And we would ask that the Medicaid patient encounter data be attached to the attestation in an Excel format. This helps us review the data more quickly, thus expediting the review and approval process of your attestation. It's not required that it be in an Excel format, but it is helpful to us because of the large amounts of data that we need to review.
The next question for the panelists is very similar to the first, about organization, but specific to patient encounter data. Could you share examples about how you organize the patient encounter data prior to attesting?
This is Stacy again. We have reports that we run weekly, actually, that either follow the full year reporting guideline or broken down by quarters as well. And the patient's level data is captured as part of those reports. And the other way that we're able to capture the patient encounter data is through our vendor as well. We have certain reports that we can run within the EMR itself that will capture the patient data. This is helpful for us because the reports that we're able to run can show us which patients perhaps are falling out, and we can then go back and look at where we need to improve on that. As far as the patient volume and encounter data, we're able to pull that information based on, obviously, the providers that we have attesting and the departments that we are attesting for. And it's just an ongoing report that we're able to generate.
Thank you. Any other panelists care to share?
Yeah, this is Angie with Nebraska Medicine. We do a little bit of a different approach, partly because out of the hundreds of providers that we have at our organization, we have a very small handful that do report to Medicaid. So we actually run our report at the very end of the year from our billing department, and then do a lot of manipulation within Excel to find 90 days of patient volume. The one thing that will sometimes catch us is that the patient volume has to be 12 months prior to attesting. So if you run that data in January and then you don't go to attest for those providers until February, you can run into instances where your patient volume time period is no longer eligible because you're outside of that 12-month period. So that will catch us sometimes at the end of the year when if we don't get our patient volume decided right away and who we're testing for. So that one's caught us a couple times.
And this is Stacy again. I guess one other comment I would make is that we, or at least I have a calendar reminder in late September to start looking at this process, because it sometimes can be a lengthy process, especially if you have to go back and forth. And obviously the patient volumes have to be approved before you can start any attestation. So we try to start that as soon as we can possibly do that, just because we know sometimes it will take a length of time to get that completed, and we certainly don't want to put ourselves in a position where we're scrambling at the last minute.
Great tip. Thank you very much.
Next slide, please. Okay, on this slide, we discuss what documents need to be attached to your attestation. And again, we offer the tip that if possible, we find that it's probably best to keep these documents electronic so that you can easily upload these documents to your attestation when you attest. One thing we request actually is verification of the Medicaid patient encounters over the 90-day period that you've chosen within the year preceding your attestation. While it's not required at the time of the testing, we often need it when we're completing our review process. So if you attach it now during your attestation, it'll save time and speed up the review process altogether. We do require verification of your certified EHR system if you have had a change in your system or vendors. If you are a physician assistant, you will be prompted to upload verification of the following: being the primary provider in a clinic, being a clinical or medical director of the clinical site where you practice, and being an owner of a rural health center. And I'd actually like to just add, this is Karen again with the EHR Incentive Program, and I would just like to add what our panelists mentioned before. Don't hesitate to reach out to us if you are looking at patient volume and aren't sure what dates to use and what time frame to use. We're happy to run some reports on our end and see if, we think you might be close to the required percentages. We have to do some manual validation of the encounter data on our end, and if we can get that information from you even before you attest and validate that data, then it will help to actually speed up your attestation process. So don't hesitate to reach out to us, bottom line, and we'll see what we can do to help you out there. Next slide, please. A little bit more about what needs to be attached to your attestation. If you're attesting to meaningful use, please include a letter from public health if you're attesting to meeting a public health measure, information from a specialized registry if you are attesting to meeting one of the specialized registry measures, your inventory list, and this is the list that you used when you completed your security risk analysis for Objective 1, which is protecting patient health information. Reports from your EHR that show meaningful use verification. If you're needing to capture a moment in time, be sure to take a screenshot and then file it in your electronic file. It's helpful to us when we're reviewing attestations if when you submit your meaningful use documents, you've highlighted the provider's name and the measures that they're attesting to. We go through a lot of meaningful use reports, and it will help to expedite the process. If the information is highlighted, we'll be able to see it more quickly and be able to validate it more quickly. Reports from your EHR that show clinical quality measure verification, and please remember that your EHR must track 9 CQMs, even if the result is 0 for any or all of them. If you are assisting multiple providers, it's very possible that the same letter, same verification, such as a letter from public health, will be attached to more than one attestation. If any documentation is missing or we require additional documentation upon review of your attestation, you will be contacted. Please note that the meaningful use in CQM data does need to be specific to the provider. It's not the overall group. Progress with meaningful use and clinical quality measures is specific to the provider.
The question we have for our panelists is, could you offer any tips on obtaining any of the documentation that you attach to your attestation?
This is Stacy. When we look to get our letters from the state regarding public health or the other types of things, we have contacts that we've used in past years, and it's basically just reaching out to them with the reporting period that we're looking at and then filing those letters in the appropriate folders to track for the most part.
This is Ruth Ann, and one of the biggest things that comes to my mind is just to work with the EHR vendor to help get the reports that you need, and they are required to get these for us, and so they can hopefully give you a lot of help with I'm thinking specifically of like the CQMs and the core measures.
Thank you.
This is Angie. Oh, I was going to say, this is Angie. I start as early as I possibly can, so I always am putting it out there to my my IT person that as soon as the security risk analysis is complete to please send it to me so that I know I have it, as well as with the state. I usually don't get a letter until the end of the year, but I send them like a little email saying, hey, I'm going to be asking for this at the beginning of the year, partly because attestation time is right around the holidays and a lot of people are gone. So I try and make myself known that I'm going to need that data, or at least know if they're going to be out of town for some reason, how long it might take me to get information from them.
That's an excellent tip. Thank you.
Next slide, please. This slide, we talk a little bit about how the calculation of patient volume is done. Out of all of your patient encounters during a 90-day consecutive period within 12 months from attesting, you need to meet or exceed a required percentage of Medicaid encounters. Hospitals, the required percentage is 10%. Eligible professionals, it's 30%. However, pediatricians can qualify for an incentive payment if they have at least 20% of their encounters be Medicaid encounters. If a pediatrician qualifies, meets a range of 20 to 30% Medicaid encounters, they can still qualify, but it is a reduced incentive payment amount. How do we define what an encounter is? The patient must have been enrolled in an allowable Medicaid program at the time that the service was rendered, regardless of whether or not Medicaid paid anything on the bill. Medicaid can be a primary, secondary, or tertiary insurer. This can be for any type of service. Only one service per day, per patient, per provider can be counted. Medicaid encounters for patients eligible for other programs, like state-funded only programs, cannot be included. And an example of this would be 599 CHIP. To give an example of what an encounter is, if a patient came in for an office visit and was also given an allergy shot on that same day by the same physician, this is considered one encounter. If a patient came in on a Monday for an office visit and came back on Tuesday for an allergy shot, this would happen to be two different encounters. Next slide, please. On this slide, we explain how the calculation of patient volume is done. You can report patient encounters by either group or individual reporting method. For group method, this is using the encounters of the entire clinic or group to reach the required Medicaid patient encounter threshold. An example would be that Dr. A sees very few Medicaid patients. Dr. B sees mostly Medicaid patients. Dr. A and Dr. B combine their encounters so that they both meet the required threshold together. Individual patient encounters, patient encounter methodology is using only the attesting provider's encounters to reach the required patient encounter threshold. For example, Dr. A sees enough Medicaid patients to reach the required threshold. Dr. B sees enough Medicaid patients to reach the required threshold. They both attest using only their own encounters and do not add in each other's encounters. It's important to recognize that if your group is attesting to group volume reporting, the numbers, the numerator and the denominator, would be the same for every provider in that group. We give flexibility to groups and providers to define the group that they're attesting with for patient volume, but we understand that this can be confusing, and definitely reach out to us. Our email address is listed in this presentation if you have any questions or considering reporting with a group methodology.
So the question I have to the panelists is, do you have any suggestions on working with patient volume threshold requirements and understanding the concept?
This is Stacy. We have a template that we save. It's a SQL query that looks out to exactly what those parameters were, looking at all encounters. We attest as a group, and we actually have to run two different reports because we have two different groups. We have a pediatrician group, which is at the 20% threshold, and then we have a specialty group, which is at the 30% threshold. So we have 2 separate reports that have saved queries on them that look to all the encounters that took place during the reporting period, and then filtering out those that had the required Medicaid, I forget what the bullet point said on the previous one, to calculate our percentages. So those reports are saved every year. When we go back and run them, we just update them with the newer dates, adding in either new physicians that have come on or new clinics that have come on in that time frame.
Thank you. Any of the other panelists?
This is Angie. We do the individual method, but we only have a handful, like 30 providers that we attest for to Medicaid specifically. We haven't added any new providers in the last couple years, so we pretty much know the providers that we're looking at, and we have billing, then we have queries saved as well, and billing runs our queries for us, and then we do some manipulation on the back end to make sure that we're finding the 90 consecutive days that they meet the patient volume.
Thank you.
Okay. Next slide, please. On this slide, we talk a little bit about what's called managed care patient panel methodology. This is the final option for using to report patient volume. It's an option to use only if you are a Medicaid managed care primary care physician. This requires the provider to maintain a record from the managed care plan which shows the number of patients assigned to them during the specified 90-day period, as well as proof of the encounters over the past year. It's not common for us to see providers reporting patient volume in this way. So please reach out to us if this is something you're thinking about doing, and our email address is listed here.
So the question I have to the panelists is a pretty simple yes or no question. Have any of you ever used managed care patient panel methodology to report patient volume? And if so, how did you decide to use this method of reporting?
This is Stacy. We do not use that method.
This is Ruth Ann, and we have never used that method either.
This is Angie. We have not used that method either.
Thank you. I think this lifts up how rare this is utilized, but thank you for the confirmation.
Next slide, please. Okay, how do I obtain my certified electronic health record technology number? Simply put, this number should come to you from your EHR system vendor. There is another way to obtain it, and that's through the CHAPEL website, Certified Health IT Product List. The website address is listed here and the directions on how to obtain that number. The certified EHR number does change at times depending on CMS and different rules, and so it's important to recognize that you most likely will not be entering the same number into the attestation year after year, and to obtain the most recent version of this number.
Panelists, have any of you had any trouble obtaining your certified electronic health record technology number? Where did you obtain this number if it happened to have changed from a prior year?
This is Stacy. We can get them from our EHR vendor. However, I use the website just to go out and upload the latest and greatest version that's out there, and then save it into the appropriate year attestation folder that we have for meaningful use. Whether or not the number has changed or not, I always get a fresh copy of it. But that's the easiest way to do it.
This is Ruth Ann, and we always look on the website as well and then make a copy of that.
This is Angie. We make sure, just because we've gone through upgrades the last couple years, we make sure that we get our license summary from our EHR vendor, and then I go into the CHAPEL and create our number or whatever, and then save that off as well.
Thank you very much.
Next slide, please. How do I get the meaningful use data I use to attest with? The meaningful use data that you're attesting with should come directly from your certified EHR system. The numbers and everything that you need should be coming directly from that system. If your EHR is not displaying it well or there's some confusion in understanding it, please go back to your vendor to clarify and obtain the information that you need. For Objective 2, Clinical Decision Support Rules, these are 5 free-form boxes that you'll need to type in the rules that you're using. Please note that these rules must be unduplicated from each other and also cannot be, you cannot list in one of these boxes drug-to-drug, drug allergy interaction checks, because this question is already being posed in Measure 2 of this objective.
Panelists, could you explain how you obtain the meaningful use data from your EHR that is reported in the attestations? For example, does your EHR print off this information? Do you have to format it into another type of document, such as Excel? In short, could you give me the logistics of obtaining your meaningful use data?
This is Stacy. We manage our provider records within our EHR, and we advance them to the next stage of meaningful use, which then drives how they show up on our reports. Our reports are batched, and they're run automatically on a weekly basis and sent out to myself and other stakeholders who are interested in the meaningful use piece. They are PDF documents that come right now, and then they are just reviewed to, just quickly spot check and see how our providers are doing. We can also run some ad hoc reports directly out of the EHR. I think I mentioned that a little bit earlier, to give you a quick glance of how many providers are meeting all measures without having to scroll through literally 300 pages of a PDF report to look at whether or not they're meeting them. So I will periodically go into the report directly out of our EHR and look at that, and then if I need to dig further into it, I will. But right now, like I said, we get these auto-emailed to a select group of users on a weekly basis in a PDF format.
This is Angie. We have something kind of similar. I know that Stacy and I use the same EHR vendor, so I take it a little bit different approach. We run more like a scorecard on a weekly basis that I can spot check my providers, and then run the PDF summary reports more on a quarterly basis. And then if I need to verify something, I can find that provider and look at their PDF summary report. And we save off each quarter into our file folder. We then, because we run all providers on our PDF summary report, we use a program called PDF Creator, and you can then search for your provider in that first PDF summary and just save off the individual data into the individual provider folder by using the PDF Creator, so we don't ever have to print our reports, and we can divvy them out from that initial PDF summary and save them for individual providers.
The other thing, this is Stacy again, I forgot to add, is we also use dashboards within our EHR to give us, again, a high-level overview for each objective, how the provider is doing. So it's a quick spot check to see, are they passing or failing certain measures, and if there's a pattern of providers failing a certain measure, is it a workflow issue, is it a system setup piece, so we can quickly gauge where we're at with each one.
This is Ruth Ann, and we actually have two different methods to look at one to look at the core measures, one to look at the CQM, and we're watching those periodically throughout the year, and like Stacy said, going to the providers then to give them that information and try to figure out within their workflows, what needs to be tweaked or changed so that perhaps things are just not being captured and they're actually doing it, but just making sure that what they're doing is actually being captured.
Okay, great tips. Thank you very much.
Next slide, please. Okay, on this slide we'll discuss a little bit about what Nebraska's review process is like and how long it takes. The review process includes 2 separate and complete reviews of every attestation by Nebraska Medicaid EHR staff. We will contact the provider for clarification regarding any information submitted. Attestation reviews are always done on a first-come, first-served basis. Our processing time depends on the number of attestations we've received and how complete those attestations are that we've gotten. If at any time you'd like to check on the status of your attestation, you can certainly reach out to us, and our email address is listed in here. Otherwise, you can log on to our portal, and the address is listed on this slide here. The first page after logging in will show you what your attestation status is. And once you've been approved, an email will be sent to the provider to notify them of the approval. It's not unusual for us to receive about 400 or so attestations at about the same time every year. And we're a small team within Nebraska Medicaid, but we do work as quickly and accurately as possible to review your attestation and hopefully get you an approval as quickly as possible.
Panelists, could you share with us how your experience has been with the Nebraska Medicaid EHR Incentive Program staff's review process for those attestations you have helped to submit?
This is Stacy. I've worked with Karen for a long time and LaVonna too, and I think we have a good working relationship. There's always, things that I think we miss that we end up having to submit additionally. I think just some suggestions that I would have is, for each provider, it takes approximately, 20 to 30 minutes to do an attestation. And when you've got a large number of providers like we do, we're testing for, almost 160 providers. It's a lengthy process. And to attach the same documents all the time to each one of them, knowing that it doesn't change might be something that if we could attach, here's our public health documentation, here's our EMR certificate, so we don't have to attach those to each individual one would be helpful. And then the other thing would be, at least a suggestion, to check on the status of the attestations. Is to be able to, again, have a single page for all of our providers to check the status instead of having to log in one by one, because like I said, we have so many of them, it's just not a feasible thing to do. I would say that, for the most part, though, we get our attestations back and reviewed in a timely manner. I hope that my staff is still able to get the information you need in a timely manner, too, because I know that, we throw all those on you, and then now we get a little bit of breathing room, and then the work effort transfers over to you. But I've, not really had any problems with it.
This is Karen. Thank you very much for that information, and I'm glad to hear that overall it's working well. Certainly, don't hesitate to reach out to us, especially if you have a lot of providers you're checking on, so you don't have to log into each attestation. We are more than happy just to see what the status is. It doesn't take us long to run a report and pull all the providers connected to a certain group and just give you a quick rundown. So it's not a problem at all for us to do that if that's easier for you.
Yeah, thank you.
Any other panelist comments?
This is Ruth Ann, and I just know that last year, for instance, we heard within 2 weeks whether we needed to that we needed to send in a little bit of supporting documentation. So that was really a very quick turnaround time for us.
Thank you.
This is Angie. I would agree with everything. The turnaround time is very quick, and you know, it's always good when you have a question that you guys get back to us very quickly, and we can keep our process moving. I would also agree to what Stacy said as far as attaching each individual document. Being able to do something as a larger group would be extremely helpful, just because each attestation does take quite a bit of time.
Thank you. Thank you for the suggestions, and I'm sure the staff will review the thoughts, and we will get back to the panelists in particular or make announcements on our websites if we change a process at all. We welcome those suggestions, and so with that, next slide, please. I would like to remind attendees that you have a chat box available if you have questions that you would like to present to the panelists or to us. We would be happy to read those off. In the meantime, we are at our webinar poll slide, and we're going to ask you to write your responses to the our email address, dhhs.ehrincentives@nebraska.gov. We are looking for suggestions about topic items for coming webinars, and so we have listed 3 that we thought might be helpful to attendees and our providers and the people who assist them in the attestation process. But this is from our view, and we certainly are interested and welcome input from all attendees. So if you have another webinar topic idea that you would like us to cultivate, we would love to see that. So with this slide, we were asking you to email us and perhaps prioritize any of the topic items that you think are important that you see up there, or individually let us know any additional topic items. And we do have a question from Robert. Have you thought about changing attestment to help with dental offices? Most of the attestment information is not related to dentistry.
Sure, this is Karen. Robert, could you expand on that a little bit, either enter a little more information into the chat window or just
unmute your phone.
Unmute your phone. I just want to make sure I know what you're asking. Are you just saying like the presentation should be more related to dentistry, or the meaningful use measures more related to dentistry?
Karen, I think the biggest thing is with us is most of the meaningful use is so oriented towards the medical field. There's very few of the criteria that pertain to dentistry, and so it's very hard for us as dental providers to discern what we need to enter when we're attesting to meaningful use. You know, for example, you know, we're going through, you know, vaccinations, OBGYN visits, and, you know, it's just the things that we've seen for the second year is, you know, cavity rates in children and possibly, you know, drug interaction, but that's really the only meaningful use that applies to us on a day-to-day basis with dentistry. And so it's, to me, it's so far outside of what we do that I was wondering if there's any way to simplify that, you know, for dentists or pediatric dentists, you know, or oral surgeons, so that it's more oriented towards dentistry. Does that make sense?
Sure, that does. Thanks for bringing that up. It's a great, great topic, great question. I know that's long been a topic within CMS. With the meaningful use measures that they set forth and the final rules that they produce is, you know, a lot of their questions don't necessarily pertain to dentistry and how to get more dentists involved with meaningful use. You know, unfortunately at the state level, we don't have, you know, control over the meaningful use measures and the questions that are asked. The good thing is, I think a lot of times with dentists, there's, at least with the questions as it pertains to attesting, there's exceptions and exemptions that can be claimed because you wouldn't necessarily be doing a lot of those things that a regular physician might be doing. And so there's still the potential to qualify for meaningful use, taking exceptions and exemptions. But it is definitely something I know that CMS has talked about for years, is involving dentists more, and you know, how to get more dentists meeting meaningful use and meeting measures that help them qualify for meaningful use. So thank you very much.
Yeah, and specifically like the 5 measures of meaningful use. It's very hard to hit all 5 of those criteria. Is it required to meet the meaningful use to have 5 different criteria?
Oh, are you referring to the clinical decision support rules, that slide that we showed in here, the little snip of it?
Yeah, exactly.
It is required to have 5, but hopefully your vendor or a dentist vendor would be able to point them in the right direction if they don't have 5 readily available, if there's, you know, some other ones that they might be able to use. I'm not sure if you had luck with your vendor or if you know, talk with them specifically about that.
Okay.
So, thanks for bringing that up, though.
Sure.
Next slide, please. So I have, as we're waiting for potentially suggestions for next webinars coming into our email, I have one last question for the panelists. It's not a question so much as asking if you have any additional comments regarding the attestation process or the EHR program as a whole. I'm wondering if we lost our panelists.
This is Angie. I really think the process as a whole, once you know what you need to attach and have all your information together and know how you're getting your patient volume, you know, it goes pretty smoothly. It's a little time consuming, but once you get in the groove and have all your stuff together in one location and ready to attach, it goes smoothly. And, you know, the staff at the EHR incentive program is very responsive and accommodating and helpful. So it really goes pretty smoothly once you have everything down, in my opinion.
Thank you.
And this is Stacey. I would agree. It's being highly organized will save you a lot of time and headache when you're doing this process. But there are little intricate pieces, especially if you have never done it or this is your, you know, first or second year doing it. It does get better with time because, like Angie said, once you get used to the process and know what you have to enter and where to enter it and what to attach and what you need to save, it becomes a lot easier to manage.
Thank you. Was that the end of the comments from the panelists?
This is Ruth Ann, and the only thing that I would just say again is to get as much help from your EHR vendor as possible. They should be able to give you a lot of help.
Good tips. Thank you very much. And so I think to sum up, in general, being organized, working in advance of attestation, contacting your vendor, and contacting the EHR incentive program staff with any questions you have are going to put you in good stead as you enter into the attestation process. So I want to thank, at this time, the panelists for their wealth of information that they shared to the attendees. Thank you for all the attendees' time and energy. I want to remind you that this has been recorded and it will be available along with the PowerPoint slides on our website at a future date soon. We have our names and our email address and our phone number and the website all on this slide. If if you have any other questions, please feel free to contact us. Do we have other questions?
No, I thought it's not quite 1 o'clock, so I thought we might stay on the line here for a few more minutes and see if anyone's got questions that they thought of.
Yeah, we have some time, so if you have any other questions, feel free to unmute your phone or type it in the chat box. And there doesn't seem to be any comments, questions in the chat box, and I'm not hearing the phone unmute, so I think we are going to bring this to a close. Thank you again very much for your time. Have a wonderful day, and this concludes the webinar. Thank you.